Hello, everyone. Thank you so much for joining me today. The title of today's talk is Glaucoma, our 2020 update. My name is Dr. Sowmya Srinivas. I practice at Dartmouth-Hitchcock Medical Center in Lebanon, New Hampshire. I have no disclosures. So the outline of today's talk will include an introduction and an overview of glaucoma. We'll review some landmark clinical trials and what we've learned from them. We'll go over diagnosis and management of glaucoma. We'll discuss therapeutics and finally close with some cases based on what we learned this morning. So why is glaucoma important to identify? And what tools and knowledge, old and new, do we have to diagnose and treat and manage glaucoma? So from this picture, you can see that the number of people over 65 years of age is steadily increasing. And people are living longer. So this is a graph of the aging population in the world compared to the United States. And it's showing that life expectancy has steadily increased. And here's a picture representing that life expectancy is increasing all over the world. And people are living much longer, generally beyond over 65 years of age, as you can see in this diagram, in many parts of the world. So the projections for glaucoma from 2010 to 2050 are shown here. And you can see that among all ethnicities, the incidence of glaucoma is expected to more than double from 2.7 million to about 6.3 million. So what does this mean for us eye care professionals? So this means we have a responsibility to provide good quality of life for our patients. So it's important to identify and treat glaucoma early on so we can have our patients enjoy a good quality of life as life expectancy is increasing. So here's our first polling question, which is, what is the definition of glaucoma? Is it 1, retinal ganglion cell loss? Is it 2, optic nerve damage with corresponding visual field defects? 3, increased IOP is a modifiable risk factor? Or 4, all of the above? So before we delve into more of the specifics, please choose the definition of glaucoma. So you did a great job. So all of the above is correct. So this is indeed the definition of glaucoma. It's excellent start. So now we'll step back and review some of the landmark glaucoma studies and how they affect our management strategies today. So the first major study was in 1998, and this was a collaborative normal tension glaucoma study. There was a few key points to take away from this study. And those were the risk of progression included higher in females more than males. And if a disc hemorrhage reoccurred on your clinical exam, they had a higher risk of progression. And any patient with a migraine history also had a higher risk of progression to glaucoma. And so this was the first study to clearly demonstrate that lowering IOP is an effective treatment for glaucoma. And in 2000, there was an advanced glaucoma intervention study. And the main takeaway points from this study included higher IOP fluctuation was associated with visual field progression. There was reduced risk of progression with consistently 18 millimeters of mercury below of IOP. And this study also showed that African Americans had less progression with initial laser treatment, while Caucasians had better outcomes with trabeculectomy. And a year after the other study came collaborative initial glaucoma treatment study, which showed that quality of life and blindness from glaucoma are a concern. So IOP lowering is beneficial in glaucoma in all clinical situations. So if their mean deviation, if a patient's mean deviation is -10 or worse on visual field, they had a more likely visual field progression with either medical versus surgical treatment. But if their MD or mean deviation was -2 or better, there was no difference if a patient was treated surgically or medically. So in other words, consider surgery in advanced glaucoma So filtering surgery is easier before eye drops are used, and major surgical complications are few. The main point is to keep IOP steady and evaluate and reevaluate the IOP, because every 1 millimeter of IOP matters when you're treating glaucoma. And the next large-scale study that came out was the Ocular Hypertension study in 2002. So this study showed that risk factors for primary open-angle glaucoma development are the following. So advancing age, increased IOP, a greater pattern standard deviation on a visual field test, thin pachymetry, in other words, central corneal thickness, and vertically elongated cup-to-disc ratio, increased cup-to-disc ratio. And the European Glaucoma Protection Study, which came a few years after this study in 2005, showed the same risk factors for progression as the Ocular Hypertension Study in 2002. So this is a representation of Ocular Hypertension Study. So observe that if a patient's pachymetry reading is less than 555 micrometers, so in other words, about 550 is average. So in other words, if they have thin pachymetry, and if their IOP is greater than 25 millimeters of mercury, they have a 36% chance of progression to glaucoma. Whereas if their IOP is thick, so anywhere above 588 thickness, they have just about a 6% progression to glaucoma. So an early manifest glaucoma trial, which came in 2002, showed that baseline risk factors included increased IOP, again, advancing age, presence of exfoliation, bilateral disease, and worse mean deviation on visual field, and also disc hemorrhage reoccurrence. So this study showed that more or less the risk of progression is less with the larger IOP drop. So the sooner we catch and identify glaucoma and treat glaucoma, the patient's risk of progression is less. As you can see here, based on control versus our treated groups. So the main clinical pearl from the landmark studies of glaucoma showed that evidence of lowering IOP reduces the risk of further progression in glaucoma, and this must be regarded now as very strong. So again, the main takeaway from all of these studies is diagnose and treat early. So as you all know, some of their diagnostic procedures for glaucoma include measuring the IOP or intraocular pressure, pachymetry, gonioscopy, clinical exam, in other words, evaluation of the optic nerve, and diagnostic imaging is used, so OCT, GDX, HRT, and of course, visual field. So we took a step back and learned about clinical studies and how each millimeter of mercury matters when we're treating glaucoma. Some of the newer parameters for earlier diagnosis and management include the following. So over the past few years, we learned that corneal hysteresis. In other words, corneal hysteresis is the shock absorbing properties of the cornea. So it's the cornea's ability, in other words, to absorb and dissipate energy. So corneal hysteresis measurement, if high, confers a protective factor for glaucoma, so less risk of progression versus a lower corneal hysteresis measurement. Ganglion cell complex analysis tests the macular area, and we'll go over how we can use this to diagnose glaucoma early on. HVF, or visual field 10-2, is another newer parameter used in earlier diagnosis and treatment. Because recall that in 24-2, only 4 test points are tested in the macular region, and these test points are spaced about 6 degrees apart. And OCT angiography has been used in the more recent days to observe blood flow to evaluate the health of the ganglion cells. So if we see loss of ganglion cells early on, we can diagnose and treat glaucoma early. And some of the newer visual field strategies include adding central points to the standard 24-2. So this is the 24-2C. And this tests about 10 additional points in the central 10 degrees. So what this does is we can detect glaucoma or central scartomas early on. And more recent studies have shown that central 10 degrees was tested relying on the older 24-2 visual field. So now we'll get into the concept of structure and function in glaucoma. So diagnosis of glaucoma can be made based on your clinical exam and imaging, like we discussed. So we correlate what we find on the optical coherence tomography, and which is the structure aspect, and functional, which is a visual field abnormality. So we use these tests to identify glaucoma, and earlier identification of glaucoma by strategic use of both of these devices may result in an opportunity to intervene as early as possible in the glaucoma disease course, and we avoid preventable and progressive vision loss. So you may have heard about glaucoma red and green disease. So when we find that the OCT color pattern is all green, we cannot assume that everything is normal. So in other words, ophthalmic imaging is an important clinical adjunct to your clinical exam. And we use these imaging devices in conjunction with our exam, but do remember that there are artifacts in imaging and there are limitations in technology because certain normative databases are used. So we'll go over some examples here next. So as you know, OCT has become an integral component of modern glaucoma practice. It's important to recognize that green disease, or when you see a color pattern which is green, we cannot assume that everything is normal. It should prompt you to a good clinical exam. It should prompt you to explore the structure function component. So in other words, if you're seeing a structural damage, does this match up functionally on a visual field test? And this way you can avoid missing glaucoma treatment if it's necessary. So here's an example of red disease. So the thinner retinal nerve fiber layer of the high myope does not conform to the normative database and is colored red. So if you observe on the optic nerve scan, there is a large amount of peripapillary atrophy. So what the OCT below is showing is there are a lot of red areas on the OCT nerve fiber layer scan. But this does not mean that the nerve fiber layers are damaged. So this happens, when you see red, you cannot misinterpret and say that this patient definitely has glaucoma. Because of their high myopia, the OCT is showing a lot of red areas, but we have to take into consideration other factors. So here's an example of quote unquote green disease. So here the OCT appears green as shaded in both left and right eyes. But if you notice on the left eye, the retinal nerve fiber layer measurement is labeled normal. But if you look at the small red arrow, it points to a focal loss inferior temporally in the left eye. But if you look at the corresponding OCT, it's highlighted green. So this is easily detectable on the posterior pole and retinal thickness map and hemisphere asymmetry analysis, which is on your right. So if you were going based just on the color patterns, you would have potentially missed the small focal defects that are shown on your right lower part of the screen. So again, it's very important to use imaging in conjunction with your clinical exam, as opposed to looking at color patterns and saying red is definitely glaucoma or green is definitely normal. So it's important to correlate structure and function. So here are visual field defects we expect in glaucoma, including nasal step, ocular defect, and others as noted below. So it's important to grade the severity of glaucoma because it can help you tailor the treatment for each individual patient. So mild is characteristic optic nerve abnormalities or consistent with glaucoma, but there is a normal visual field. Moderate glaucoma means visual field abnormalities are one hemifield and not within 5 degrees of fixation. Severe glaucoma is when visual field abnormalities are in both hemifields and the loss is within 5 degrees of, fixation. Glaucoma can also be staged on mean deviation patterns, mild, moderate, and severe. You can see the 30-2 CETA cutoff points on your left-hand side and 24-2 visual field CETA based on the right-hand side. So we talked briefly about ganglion cell layer analysis in the macular area and how it's important to use that aspect in diagnosis and management of glaucoma. So A, which is the top left-hand portion of your screen, shows the ganglion cell layer image of the patient's left eye. In the middle is a retinal nerve fiber layer map. And on the right-hand side is a visual field. So ganglion cell layer, if it's shaded red, is actually normal. So if you look in A, the ganglion cell layer is actually quite robust and normal. So red is normal. And you can see that this patient has a very strong, robust, and normal ganglion cell layer in A. The retinal nerve fiber layer also looks excellent in this patient's eye. And therefore the visual field is normal. So these are correlating and corresponding with each other, showing that this patient has normal ganglion cell retinal nerve fiber layer and functionally has a normal visual field test. If you look in B, you'll see that the ganglion cell layer is damaged. Damaged inferior temporally here. And the retinal nerve fiber layer also shows some thinning on the inferior portions. And therefore the visual field matches with that early superior loss. So this is corresponding with each other. So this is how you use their testing. So again, structure and function, which is a visual field. In C, you can see that there's absolutely no red. So the ganglion cell layer is very thin. And the retinal nerve fiber layer also shows a thinning pattern, especially inferiorly. You can see that the ganglion cell layer is, you don't see any evidence of any ganglion cell layer. And the superior field loss is corresponding to both of these images. So again, this is a great way to use ganglion cell layer thinning, the retinal nerve fiber layer to correspond to your visual field defects to help identify glaucoma early on. So now we step into the management of glaucoma. So here, glaucoma suspects or glaucoma diagnosis. So again, if present, we have to stage the disease, as we learned, mild, moderate, or severe. And then we assess the risk. So we look at age, we look at patient's IOP, we look at pachymetry, severity of damage, whether glaucoma is unilateral or bilateral. We look at the presence of disc hemorrhages and family history. It's important to note that the risk of glaucoma is higher if a sibling has glaucoma. And then we come up with our treatment plan and surveillance. So we establish baseline with OCT and visual fields and photographs, and then monitor based on the severity of diagnosis. So we discussed how the risk of glaucoma is higher if a sibling has glaucoma. So this study by Sung et al. Showed that siblings of glaucoma patients have a higher increased risk of developing glaucoma, and the risk increases with age. So the way I use this in my clinical practice is to ask patients if they have siblings with glaucoma. And in that case, I can monitor them closely and start treating early on if I see any signs of glaucoma. You can also urge, patients, if you see glaucoma in an individual's eyes, you ask if their family members, especially siblings, have been tested for glaucoma. And so this way we can catch and identify and treat glaucoma early on, knowing that siblings have a higher risk of, siblings of glaucoma patients have a higher increased risk of developing glaucoma. So here's your next polling question. What is the best type of imaging to use to detect progression in mild to moderate stages of glaucoma? So we'll go over this next. So it's very important to remember that the best method to detect progression varies depending on the stage of the disease. So you are right, we use both tests, but remember that in mild to moderate glaucoma, an OCT is more effective, but there's a concept called floor effect. So about 55 or 60 micrometers, the OCT starts to bottom out. So which is why in moderate to advanced glaucoma, we would use a visual field test. So going back to this question, what is the best type of imaging to detect in mild to moderate glaucoma? The answer is actually A, OCT. And we'll go over this concept on the next slide. So this concept is important to remember. So this is the floor effect of on the OCT devices. The floor effect happens at approximately 50 to 60 micrometers. It varies on each OCT device. And this happens because the average retinal nerve fiber layer measurement never goes to zero with advancing damage. So you're bottoming out at 55 or 60, and it does not go any lower because in addition to the nerve fiber layers, the optic nerve is comprised of glial and other structural tissue, which accounts for 40% of its makeup. So for that reason, we'll see in a case example that there is a floor effect on OCT, and we can only use OCT effectively in mild to moderate stages of glaucoma. And then when the moderate to advanced stages of glaucoma, we best rely on visual fields. So there are a couple of ways to measure progression. The first one is trend analysis. So trend means rate of change. So this is a regression line drawn to determine the rate of change for data collected over time. So here we can use visual field index or mean deviation or retinal nerve fiber layer thickness to monitor trend analysis. And the slope or percentage of rate of change is calculated. And this is most valuable when multiple visual field tests have been performed. And this trend analysis, which is a measure of progression, is good for identifying fast progressors and generalized or large field defects. So here's an example of trend analysis. So on your y-axis is the visual field index. On the x-axis is the rate of progression. So in this particular patient, we have several visual fields that have been performed, and we can see that, with good confidence that they are remaining essentially close to 100%, which means if their therapy is IOP therapy is stable, then this patient has a very high likelihood of maintaining good vision for many years. So the second way to measure progression is event analysis. So event analysis means, has this changed compared to baseline or consecutive tests? And this is a point-by-point basis look at the testing. So it is mostly used in early follow-up time period, but it's also helpful in middle and late stages of the disease. So here, what you would look for are shaded triangles indicated by a single point, which is worsening over consecutive tests. And the event analysis is good for identifying slow progression and focal defects. Here's an example of event analysis. So on their top visual field, this is from August 2017, there are shaded triangles in the inferior portion of the visual field. And this indicates a single point which is changing over consecutive tests. This particular patient happened to improve in the follow-up testing, but if things were worsening, you would look for these shaded triangles to identify slow progression or focal defects to appreciate the change for event analysis. So this brings us to visual testing. So how many visual field tests are needed to detect change? Many studies have shown that insufficient testing can fail to detect glaucoma progression. So based on this particular study by Chauhan in 2008, it showed approximately 6 visual field tests over 2 years, or approximately 1 visual field test every 4 months is needed for a patient who is progressing at -2 decibels a year. So in other words, if we do insufficient testing, we can fail to detect glaucoma progression. Which brings us to our next point. So I have many patients in my clinic who have a hard time doing visual field tests because if you look at the CEDA standard 24-2, the approximate time it takes to run a CEDA standard 24-2 is about 5 to little over 7 minutes. CEDA faster is up to 50% faster, and this study by Heigel and al. Showed that all 3 tests, so CEDA faster 24-2, CEDA fast, and CEDA standard, had similar retest variability over an entire range of threshold values. So in other words, if a patient has a hard time focusing or concentrating for a CEDA standard, you could consider doing a CEDA faster 24-2 or CEDA fast 24-2 and still be able to manage glaucoma appropriately. So this brings us to treatment. So as we discussed, it's important to slow the progression of disease or blindness as patients are living longer, and we have to give them a good quality of life and prevent progressive vision loss. So the goal here is to lower IOP medically or surgically, but when we're doing that, we have to consider burden of treatment and the cost of treatment. And compliance becomes a huge issue. So this is one study which showed the total non-compliance was about 16%, and full compliance was only 50%. So it's really important to remember compliance when it comes to treating glaucoma patients. So next we'll talk about advances in therapeutics. So there are a new class of prostaglandin analogs which were introduced in 1996, and this set high standards due to effectiveness and dosing and minimal side effects. Remember, this is dosed once at night. And several combination drops have been approved in the recent years, and there have also been advances in surgical techniques such as SLT and MIGS. So the mechanism of medications, so prostaglandin analogs, work by increasing uveoscleral outflow. Beta blockers decrease aqueous production. Alpha adrenergic agonists decrease aqueous production and increase uveoscleral outflow. Miotics increase trabecular outflow, and carbonic anhydrase inhibitors decrease aqueous production. So this is a quick review of mechanism of medications used in glaucoma therapy. And here are specific medications and the drugs that work by trabecular meshwork, uveoscleral pathway, or aqueous humor. So latanoprost blue nard works with using our two pathways. So the aqueous humor outflow and the dual mechanism of action of latanoprost blue nard is depicted in this diagram. So the green arrow, demonstrates conventional outflow through trabecular meshwork and Schlem's canal. The yellow arrow designates the unconventional outflow pathway into the ciliary muscle and to the suprachoroidal space. And both of these pathways are used and are increased by latanoprost blue nard. So the pharmaceutical landscape over the past few years included the following: the prostaglandin analogs in 2017-2018 by Zolta, as we learned in the previous slide, increases uveoscleral outflow and relaxes TM. And so this was shown in the Apollo and Lunar phase 3 studies, and it showed lower IOP compared to timolol alone, monotherapy. Latanoprost emulsion, or Zelpros, has no BAK. It does have a different preservative. And the Rho kinase inhibitors, Rhopressa, enhance trabecular meshwork outflow and reduces the episcleral venous pressure. And Rocket 1 and 2 phase 3 studies showed that Rhopressa was non-inferior to timolol. And MERCURY 1 and 2 studies showed that fixed combinations of Rhopressa and latanoprost had a greater reduction in IOP compared to monotherapy alone. So here's another quick overview of the Rocket and MERCURY trials with Rhopressa and latanoprost. So fixed dose combination of both of these medications were superior in decreasing IOP at all our time points over a span of 3 months. Patients achieved at least a 30% reduction from baseline IOP. So this was in comparison to the monotherapy, so either Rhopressa or latanoprost monotherapy. So some clinical pearls based on what we've learned so far. So progression detected using clinical exam, photographs, imaging, and visual field are extremely important in diagnosing and managing glaucoma. So it's important to be vigilant and detect change early on. And it's important to remember that we have to perform enough tests to establish baseline and be able to monitor and detect change. And over time, with stability, we can reduce the interval for testing, but if change is detected, we need to modify the exam and testing interval. So the main concept, the huge clinical pearl here, is diagnose and treat early for glaucoma. So next we'll jump into some of some cases. And here's a case of a 78-year-old Caucasian female. She has 0.8 cup to disc ratio in both eyes, as you can see on the fundus imaging, or fundus photos. The IOP is low to mid-teens. Angles are open on gonioscopy. There's no pigment dispersion syndrome, no pseudo-exfoliation. Average PACI, so about 560 microns. There's no family history for this patient. And the optic nerve cup to disc ratio has been noted to be this way since 2011. Here are her OCT and rate of progression on her visual field. And her visual field index has been about 100% in both of her eyes. So we come to our next polling question here. What is your diagnosis for this particular patient? Do they have mild open-angle glaucoma, moderate open-angle glaucoma, severe glaucoma, angle closure glaucoma, or physiological cupping? Correct. So majority of you chose physiological cupping, which is correct. So if we look back as a quick review, her nerves are large, but her testing has been stable over many years, and so therefore physiological cupping is the right answer for that particular patient. So here's our next case. So this is a 45-year-old Caucasian female. As you can see in the nerve photos, she has tilted nerves, peripapillary atrophy, and borderline cup to disc ratio. Her IOP mid-teens. There's no pigment dispersion, pseudoexfoliation. She has average pachymetry. Angles are open to ciliary body band, so open angles on gonioscopy. Normal OCT, normal 24-2, and no family history of glaucoma. So here is this patient's optical coherence tomography retinal nerve fiber layer scan. And her visual field test in both her left and right eyes. So this brings us to our next polling question. What is your diagnosis for this patient? Mild, moderate, severe glaucoma, or would you watch this patient as glaucoma suspect? Exactly. So I would watch this patient as glaucoma suspect. She is myopic, and there's a higher risk in myopic patients. I would definitely watch this particular patient as glaucoma suspect. So here's another case of a 67-year-old Caucasian female. She's been diagnosed with mixed mechanism glaucoma and pseudoexfoliation in both eyes and pseudoexfoliation in her right eye. So she's had PIs in both eyes and cataract surgeries in both eyes. And her baseline IOP was 23. Her PACI was 560, and her recent IOPs have been within target, so less than 18 OU on timolol, which she reports good compliance with, and she uses every morning in both eyes. So here's a optic nerve, retinal nerve fiber layer scan on the left-hand side, and on the right-hand side, the ganglion cell layer is robust in both her left and right eyes. And here are her visual fields. So based on these tests, it tells me that her IOP is managed very well, and we're using all of the imaging modalities here to make sure that this patient is compliant with therapy, and we're using optic nerve scans, the ganglion cell layer, and visual field to make sure her IOPs are within 18, as this shows the glaucoma has been managed well in this patient's case. So here's a 75-year-old Caucasian female, chronic open-angle glaucoma. She's had history of SLT and ALT in both eyes. Her PACIs are thin, so 540 in both eyes. And her target should be within 20 and on Latanoprost and timolol. So here's her right eye. So the retinal nerve fiber layer, the ganglion cell, and the visual field of her right eye. So notice how the ganglion cell layer is essentially gone temporally. And because of that reason, you are seeing nasal defects in the right eye. So again, matching structure, retinal nerve fiber layer, ganglion cell, and function. So because of the thinning of the temporal aspect, you can see some nasal defects on her visual field in the right eye. Here's her left eye. There is some thinning of the ganglion cell. Here's a retinal nerve fiber layer scan, as well as her visual field in her left eye. And because of the thinning of both the ganglion cell layer and the retinal nerve fiber layer, the functional component of the visual field is being picked up inferior nasally in her left eye. So again, another example demonstrating how we use retinal nerve fiber layer, ganglion cell, and visual field to monitor and manage glaucoma. So here's a 54-year-old Caucasian male, chronic open-angle glaucoma, left more than the right eye. IOP on the date of the exam was 18 in the right, 26. And if you notice, his Tmax was 25 and 34. So the pressure in his left eye is coming, approaching Tmax. There is a family history. His Packies are very thin, 506 in the right, 509 in the left. Angles are open on gonioscopy. He's on Travatan Z in the left eye. And Alphagan was added twice a day in his left eye. And in the past, Latanoprost, Lumigan, and Timolol were ineffective, and he's not had any surgery. So again, remember his age, so 54, pressure is 1826. Here are his visual fields for his left and right eye, starting from 2017. There's one in 2018 and 19. And the rate of progression for both his right eye on top, left eye on the bottom. So for this patient, what is the next best course of action? Would you A, add another drop? B, would you refer this patient for to a glaucoma specialist for considering surgical options? Or would you continue to monitor this patient? Exactly. So majority of you said refer to glaucoma specialist for surgical options, which I agree with. So again, he's young, so he's 54. His IOP at the most recent exam was 26. Remember Tmax was 34. Thin Packie, family history, and poor response to 3 different drops. So this is someone we would definitely refer for surgical options. Next case, 69, Caucasian male. And on his most recent exam, sectoral thinning inferior temporal was seen. His eye pressure was 17, 18 during this exam. His Tmax was 18 in the right, 22 in the left. Packie about average. Angles were open on gonioscopy, and there was no family history of glaucoma. And the OCT on your left-hand side of the right and left eyes was a baseline OCT. And the follow-up, which we did on the date of the exam, did show that inferior temporal thinning I had noted in his optic nerve on the clinical exam. So this is the area of concern, inferior temporal thinning. And the follow-up OCT did show that particular area of thinning on his left eye. And so the visual field of the left eye is on your left-hand side, right eye is on your right-hand side. So there are functional defects here as seen in the visual field of his left eye. This brings us to our next polling question. So for this patient, would you start treatment? A, yes, because there are early superior nasal defects corresponding to the inferior temporal borderline thinning. Would you repeat the visual field testing, or would you continue to monitor this patient? Correct. So A and B are both very reasonable responses. If we step back, I went with A, but B is also, if you wanted to repeat the visual field testing one more time to see if the defects are repeatable, that would have also been a reasonable approach in managing this patient. But I went with A. So I did start this patient on treatment based on the early defects corresponding on the structure and functional tests, as well as my clinical exam. So here's your next case. So 60-year-old Caucasian female. You can see nerve photos of her right eye above, left eye below. Observe the PPA in both of her eyes or peripapillary atrophy. So their disc shows some diffuse thinning on clinical exam, and it is also seen on the retinal nerve fiber layer scan. Her cup to disc ratio was 0.85 in both eyes. She had trap surgery about 10 years ago. Her IOPs have been stable at less than 12 in both eyes. And her global thickness was 622 for her right eye and 76 for her left eye. So the reason why I had this case up was we talked about how it's important to manage glaucoma looking at your clinical exam and your testing. But it's important to notice that in her left eye, even though the retinal nerve fiber layer scan is showing, all this green, it's important not to, it's important to take into consideration your clinical exam. So her cup to disc ratio was 0.85 in both eyes. So, she was not treated in one eye, but rather both eyes, with surgery, trap surgery 10 years ago. And it was important not to ignore, the left eye showing green, that, things were normal. So again, it's important to go based on your clinical exam, imaging, and not just based on the color pattern of your testing. So here's another case, chronic open-angle glaucoma, left more than the right eye. So 57-year-old Caucasian female, family history of glaucoma in her father, had a history of ALT and trabeculectomy in both eyes. She was lost to follow-up for more than a year. Her most recent IOP was 14 in the right and 20 in the left. So recall that her left eye has more disease than her right eye. And this patient self-discontinued Latanoprost in both eyes. So here's an image of her right eye and left eye on retinal nerve fiber layer scan and nerve photos. So the global thickness was 76 in the right eye and 50 in the left eye. So remember how we talked about the floor effect on OCT. So in mild to moderate cases of glaucoma, we can use OCT to manage, but her OCT is bottoming out at about 50 in her left eye. So here's a visual field of her right eye and left eye. So there's an inferior nasal step to even an inferior early arcuate in her eye. And recall that her eye pressure was 20. So here we have a patient 57, poor compliance. She's not following up as advised, and she has self-discontinued Latanoprost. So for this particular patient, it's really important to be aggressive with therapy and hone in on the importance of compliance with therapy. Again, she's young, poorly responsive to follow-ups and medications. So this is a 77-year-old Caucasian male. He was monitored as glaucoma suspect, seen in 2015 for a second opinion as to whether he had visual field loss, and if so, whether this patient had glaucoma. Severely tilted optic nerves with peripapillary atrophy, no family history. IOP was in the mid to upper teens for many years. Tmax was 18. His angles were open on gonio, mild hyperopia, astigmatism. And here's what you see when this patient presents to you for a clinical exam. So this fundus photo shows a Drance hemorrhage in his right eye, inferiorly. So note their Drance hemorrhage inferiorly. We step ahead, we get the optic nerve scan. But notice how the quality of the optic nerve scan is poor, especially in the right versus left eye. So we cannot meaningfully use the optic nerve scan for this particular patient because of the artifacts due to his large amount of PPA or peripapillary atrophy and the tilted nerves. So here are his visual fields for both the right and left eyes. And the rate of progression for his visual field in the right eye above and left eye below. So for this particular patient, it's important that I brought him back in about 1 to 2 months to check on his Drance hemorrhage and kept a very close watch on his glaucoma progression because of the presence of Drance hemorrhage. And again, important to use your clinical judgment and not just rely on the imaging for this particular case. And finally, monitoring progression using OCT and visual field. So this is an example of a 63-year-old Caucasian male. He had severe pigment dispersion glaucoma. He was on Latanoprost nightly and brimonidine twice a day in both eyes. Pachymetry was thin, 527, 537. His eye pressure had been stable at less than 11 in both eyes. And here are his retinal nerve fiber layer scans. And the global thinning, I know it's hard to see on your slide, his global thinning was 54 and 55, and in his right eye, and 47, 45, so baseline follow-up scans. And remember how we talked about the floor effect on OCT? So his OCT is not meaningful because it's starting to bottom out at about 40s or 50s. So it's important to rely on his visual fields at this point due to severity of glaucoma instead of, it's still important to get an OCT, but rely on visual field due to severity of glaucoma. So I wanted to emphasize that point. We're beyond global thickness of 40 to 50, the OCT bottoms out. So it's important to use your visual fields for managing. So fortunately, though, this patient has been stable, as you can see on his visual field test, and the rate of progression is holding in a stable pattern, as evidenced by this graph here. So to wrap up, it's very important to use good clinical judgment in glaucoma. It's important to carefully observe and document the appearance of the optic nerve on clinical exam. You must obtain baseline imaging, and you should utilize diagnostic testing, but please remember that do not let their testing make their diagnosis for you. Be aware of red and green disease on OCT. Never ever, diagnose red disease as glaucoma and green disease as normal. It's really important to put your imaging and your clinical exam together to manage, treat and manage glaucoma. And the most important thing is diagnose and treat early, because every 1 millimeter of mercury of eye pressures matters in glaucoma. Thank you so much for your attention this morning. I'm happy to answer any questions you may have. So medical and management of uveitic glaucoma is very similar. We have our drops, so it's important to make uveitic glaucoma can be aggressive, so it's important to manage IOP using the testing and managing because of the aggressive nature of uveitic glaucoma. So in the ocular hypertension study, corneal thickness, if high, confers a protective factor for glaucoma. So if a patient has thick pachymetry readings, they have a protective factor for glaucoma. So it is based on pachymetry and IOP reading. Thick corneal thicknesses is protective for glaucoma. So low tension glaucoma is when there is damage to the optic nerve, but the eye pressure measurements are still within normal range. And the best management options are medical and surgical for low tension glaucoma. And the reason being, it's important to lower the IOP more than their baseline, just because the optic nerve does show damage. So it would be, you would use the same medications and surgical options for lower tension glaucoma. So the goal is to lower their eye pressure more than the baseline. So recall that OCT angiography shows the health of the ganglion cells. So if there is loss of the ganglion cells early on, this is a good way to detect and treat glaucoma using these the newer imaging modalities. So it is important. Structural loss is, there's not always a clear-cut correlation between structural and functional loss. So it's important to remember that not all cases of glaucoma have a very clear pattern of structural and functional loss, which is easy to pick up on the exam. So sometimes you may need some more testing. There's some gray areas, but it does make our diagnosis and treatment easier if there is a strong correlation between structural and functional loss. So optometric management of cases in glaucoma does include eye drops. So we would use the variety of drops that we would have in managing cases of glaucoma. So besides the use of drugs such as Latanoprost, what are the other treatments? So there are many classes of medications, ocular hypotensives, which we can use in glaucoma, and surgical options are also other treatments for glaucoma. So can SLT be used as a first-line treatment of POAG? It certainly, could be, but it's important to maybe try with medical treatment first prior to surgical treatment. But it could, be the first-line treatment of glaucoma, say if medications may have failed in the past. So the question is, start usually with one drug. If advanced at initial finding, what drug would you start for treatment? So generally, the first line of treatment I use for glaucoma is prostaglandin analogs, and then I would consider beta blockers. But of course, with beta blockers, you have to consider patients' any medical history of heart or lung issues, because beta blockers may be contraindicated if someone has heart or lung COPD or other heart problems. So generally we start with prostaglandin analogs. The advantage with prostaglandin analogs is the dosing. So the compliance can be high because the medication is dosed once at night. But if they need additional therapy, beta blockers would be the second line of treatment. So how effective is a combination of latanoprost and timolol, and in absence of OCUT and HVF, what can be done in glaucoma? So I think the combination of latanoprost and timolol are very effective. Again, latanoprost or prostaglandin analogs are generally a good first-line treatment for glaucoma, and we can then add beta blockers or timolol based on their eye pressures and the amount of damage. And in the absence of OCUT and VF, what can be done in the diagnosis of glaucoma? Fortunately, I've had access to the imaging at the clinic I work at. So I've always used my clinical exam as well as OCT and HVF to make diagnosis. But certainly in more severe cases of glaucoma, it's very easy to pick up optic nerve damage, but there are many cases where the damage is subtle. So, we would have to rely on imaging when it comes to managing glaucoma. So normal tension glaucoma means there is damage to the optic nerve, but the eye pressure is usually within normal range. So it's important to use good judgment in identifying normal tension glaucoma and treating, lowering their eye pressure even further to prevent visual field and vision loss. So the question is about compliance to glaucoma, whether it's, in certain cultures, if this could be increased. Compliance, I think, is an issue pretty much across the board. And the reason I think compliance is an issue when it comes to glaucoma is, especially primary open angle glaucoma does not have any symptoms. So if a patient may feel that since they're not having any symptoms, may be okay to ignore the therapy that has been advised that they be on. However, it's important as healthcare professionals from our part to emphasize that even though glaucoma has no symptoms early on, vision loss is significant in later stages of glaucoma. So I think it's really important to hone in on that particular aspect and have the patient be compliant with the therapy. Otherwise, as we discussed before, life expectancy is increasing, and our goal is to make sure that our patients have a good quality of life and prevent progressive vision loss that can happen from glaucoma. So I don't think compliance is culture due to cultures. I think it's pretty much across the board, and I think as healthcare professionals, it's important to address that and say, even though there are no symptoms when it comes to early stages of glaucoma, it's highly important to be on therapy. So what is the best management for angle closure glaucoma and low tension glaucoma? So recall that angle closure, usually their treatment would be surgical. So peripheral iridotomy is recommended for angle closure glaucoma. And then when they develop open angle glaucoma later on, that is called mixed mechanism. So mixed mechanism glaucoma essentially means that the patient had angle closure glaucoma in the past, which were for which peripheral iridotomy surgery can be done. And then if the optic nerves get damaged, then that would be open angle glaucoma after. And so this particular type of glaucoma is called mixed mechanism glaucoma. And low tension glaucoma, again, is when their pressures are normotensive, but there is optic nerve damage. So this is the, for low tension glaucoma, best management includes eye pressure drops, lowering drops, as well as surgical options. So what is the average of thin and thick Pachy limits? Average is about 550 microns for pachymetry. And so thin, I would generally consider 530, 540, and thick 560, 570 would be about thick. So 550 is about average for pachymetry. So when there is a defect on the temporal side of the ganglion cell, visual field will show a nasal defect. So I think the question was to explain this point. So remember that, there's, retinal nerve fiber layer loss inferiorly on the OCT. It would show up as superior visual field defect. So, that is why, the pattern of is seen in that way. So the question is, when there is no OCT and visual field and patient has cupping and high eye pressure, what is the best line of treatment? So if you don't have access to imaging and the patient, clearly has a large cup to disc ratio and high eye pressures, I would say, treat the patient, and you can then refer to a clinic that may have, some imaging where they can monitor glaucoma. But if there's high IOP and increased cupping, there are many studies have, as we reviewed here, have shown that high IOP is a risk factor for glaucoma. So it's important, especially with cupping, large cup to disc ratio, to treat the patient first and then refer, for effect. So what is the OCT floor effect? Can you please explain? So OCT floor effect is when you obtain OCT imaging, and in the center of the optic nerve scan, you'll see what they call global thickness. So, and this starts to bottom out at about 50, and just because, there are other components of their optic nerve, it'll never go to 0. So if you have an advanced, moderate or advanced glaucoma patient, it'll start to bottom out at about 50. And so that is why it's important to remember that in mild to moderate cases of glaucoma, you can use OCT meaningfully, but in moderate to advanced stages of glaucoma, when the OCT, particularly when the OCT reaches that floor effect, in other words, a global thickness of 50 or less, it won't go to 0. So you cannot rely on OCT for the moderate to advanced stages of glaucoma. So this is a good question. How do you define the IOP target? So it's important to define the IOP target based on the risk factors. So here we consider the corneal pachymetry, family history, and their age. And so generally remember that prostaglandin analogs reduce the eye pressure by where you can expect a 25–30%, at best decrease. And so it's important to set that IOP target based on risk factors. So again, we use risk factors to define how to target the IOP drop in glaucoma patients. So is MD more important or PSD? We use both of these. I look at all of the measurements that we would get on a visual field analysis. So it's important to look at both MD and PSD in glaucoma visual field analysis. I think the other question was significance of mean deviation and pattern standard deviation. Again, important to look at both of these, criteria. It's also important to consider cataracts, because if a patient has dense cataracts, you'll see generalized depression, but on the pattern deviation, you can see any specific glaucoma loss. I believe we answered the average PACI was about 550. So anything less than that is generally considered thin, and anything more than that is generally considered thick. So management of normal tension glaucoma, again, medically and surgically, based on the damage to the optic nerve. So the question is, how do you choose glaucoma medication as guidelines? So again, prostaglandin analogs are a good first baseline treatment for glaucoma, and then start with beta blockers as a second line, or depending on the severity, you can also consider other classes of medications, or add or subtract. So thank you all so much again for attending my lecture today, and thank you so much for your questions. I really appreciate you all joining me.